Hello, PTA students. I hope you guys are doing well. Today we are going to talk about stretching. Okay, stretching. Okay, maneuver designed to increase mobility of soft tissue. It improves range of motion by lengthening structures that have shortened or become hypomobile over time. Some other definitions: flexibility and hypomobility. So flexibility is the ability to move joints through an unrestricted range of motion. Now, this is dependent upon the muscle's length, the joint integrity, and the soft tissue extensibility. Dynamic flexibility is how far you can move actively with active movements. Passive flexibility is how far you can move passively when something else is moving you. Hypomobility is just decreased or restricted movement. And remember, hyper, ER, mobility would be excessive movement. Sometimes we allow hypomobility if that decrease in mobility increases their function. We've talked about before, if somebody has a claw hand deformity, leaving it that way if they're using power mobility, and that helps them have a better grip for their mobility. Or if maybe they have tightness in some of the muscles in their core or legs after a spinal cord injury, if they have tone there, if it helps with sitting balance, you might leave that as well. More definitions. Mobility is the ability to move versus extensibility is the flexibility of structures that cross a joint or surround it. Functional range of motion and functional mobility, pretty much the same thing. So the functional range of motion, you can move far enough to complete your daily functional activities. Functional mobility, it talks about the control of that movement. So you're able to initiate, control, sustain the movement. So functional range of motion, you're just able to get there. Functional mobility, you're actually able to use it in a useful way. So you have to have some coordination involved in functional mobility. A contracture is a area that has adaptively shortened. It could be the muscle tendon unit. It might be another soft tissue, and it limits the range of motion, which also limits function. That is a contracture. They're named by the site of the joint that is tight. So like in the picture, how it's pulling her finger into flexion, that would be a flexion contracture. Most of the time we get into contractures towards flexion because we are sitting and staying in a flexed position. And so most contractures go towards flexion, hip flexion, knee flexion, elbow flexion, all of those things. Types of contractures. We have several slides that we'll go through with different types of contractures. The first is myostatic. This means there's no muscle pathology, so the muscle fibers are normal. And it typically responds well to stretching. So this first picture is actually a little boy who had broken his arm. He had a cast on his arm while it was healing and just got the cast off. When it came off, his arm was very stiff and stuck in that position. There's nothing wrong with the muscle. There's nothing wrong with the brain signal coming to the muscle. It's just that it's been stuck in a position for a long time. And so that one responds the quickest to stretching techniques. So as he moves it, and if he has physical therapy and they mobilize it, then it should typically respond within about 3 weeks. He should return to his normal movement as long as he's having therapy and they're pushing him through his full range. With pseudomyostatic contracture, the muscle tissue itself is normal, but they're getting an abnormal signal from the brain. So typically in someone who has cerebral palsy, or if they've had a stroke or brain damage, then there are abnormal signals coming from the brain going to the muscle that cause the muscles to tighten up. Those are pseudomyostatic contractures. So myostatic, nothing's wrong with the muscle tissue or the nerve impulses that are coming to them. It responds very quickly to stretches. Pseudomyostatic, although the muscle tissue is normal, they're getting abnormal signals that tell them to constantly contract, and so it's a little harder to fight against. Arthrogenic, so arthro, remember, is joint, so it's a restriction within the joint itself. It may be from long-term arthritis or from severe rheumatoid arthritis or something like that. Versus periarticular, this is a shortening of the connective tissue that attaches to or crosses a joint. So arthrogenic is within the joint. Periarticular, which means like around the joint surfaces, around the articulating surfaces, would be around the joint. It crosses the joint. Fibrotic, fibrous adhesions within the connective tissue, and the joint structures limit the motion. So here it's maybe a little hard to see, but it looks like she had some type of maybe a burn or a significant size wound, and once it healed, there was significant scar tissue, and that can cause a fibrotic adhesion that limits movement, especially if it crosses a joint. An irreversible contracture is once the normal muscle and the connective tissue is replaced by fibrotic adhesions, like basically scar tissue, or even by bone, then it becomes irreversible. So if a person's arm is stuck in a position for so long that the tissue components change and become a different type of tissue, a more non-contractile tissue versus muscle, which is a contractile tissue, then those changes are irreversible. They will have a contracture for life. And there may be some surgeries that could reverse that, but other than surgery, that would be the only option. Selective stretching. This is what I was talking about with the claw hand deformity. So you're stretching some muscles and you're avoiding stretching others in order to improve function. So if the deformity in the hand allows for increased power mobility, then you don't stretch those tight muscles in the hand because they need that in order to move around. The main thing in this is function is the most important factor. So if a tightness in this area is more functional, leave it. If weakness in this area is more functional, leave it. If it's not, then try and fight against it. Try and strengthen or try and stretch an area in order to assist the patient. So this is selective stretching. Another example was like tightness in the legs or the core that might help with sitting balance. You wouldn't push stretching those areas to decrease the tone just to get normal muscle length if that's not going to increase their function. Overstretching, this is when you're stretching beyond the normal limits. It may be necessary in some athletes, like a kicker, so if they need excessive hip extension or flexion, or a cheerleader that might want their leg to go way behind their head, something like that, then that would be the case there. The problem with overstretching, and the reason you would only want to do it in certain instances, is if you overstretch an area, that area also becomes less stable. So if you continuously overstretch, then you're setting yourself up for a higher risk of injury. Also, if you overstretch tendons, I have this toe walker as an example. Children oftentimes, when they have sensory issues, they'll have to walk on their toes in order to avoid touching the ground with their feet. And over time, the tendon will shorten. They can do like serial casting or things where they basically make a cast that holds them in a dorsiflex position, and every few days or week or so, they make a new cast that puts them in more dorsiflexion until they have normal range of motion. The only issue is if they put them into too much dorsiflexion and overstretch the tendon, it will not shorten again. So the tendon will not shorten. Now, the reason it shortened in the first place is because they grew without using their full range of motion, and the tendon didn't need to grow to get them to a place where they could dorsiflex. And then when you stretch the tendon, it's now stretched out, but it will not go back to its prior length. So if you overstretch a tendon, you can, like let's say the Achilles tendon, lose complete function of the gastroc, because then as the gastroc, like, it's hard for me to I give weird examples, but if this is the gastroc muscle, and at the bottom right here is the tendon that attaches it to the foot. The keys are the foot. Then when I pull on the gastroc, it's the tendon itself that pulls on the muscle or the bone and allows the movement. If that tendon is so weak that it's just hanging there, it doesn't matter how much I pull on the gastroc, it never will actually pull up the bone. Okay, so if it gets the tendon's all stretched out and it's just hanging there, I can activate the muscle as much as I want, and it never has enough tension to pull on the bone. So we never want to overstretch a tendon. All right, tissue changes with stretching. And I'm sorry, some of these slides are really wordy. I went through for hours the last couple of days trying to decrease the wordiness of the slides, and some of them I was somewhat effective. Some of them you can see I wasn't. So I tried to underline some parts so you could at least know what was key on there. So these are some definitions of some tissue properties and the changes as you stretch. So elasticity, this is the ability to return to resting length quickly after stopping a stretch. So you move your arm through full range and then you return to its normal length. You stretch your wrist and then you return it to normal length. That's elasticity, the ability to return back to its normal length. Whereas viscoelasticity at first, so it's like if you are stretching your hamstrings, at first you feel tightness in your hamstrings. It's kind of resisting that stretch. And then as you hold it longer, you feel it begin to relax. But once you stop stretching, it slowly returns to the resting length. So elasticity is in muscles and some other tissues, but it's in contractile tissues. But viscoelasticity is only in non-contractile tissues, so like ligaments, tendons, fascia, things like that. But this allows the area to slowly gain more length. So rather than if it's already too short and too tight, with elasticity, if you stretch it, it goes right back to short and tight. With viscoelasticity, you hold it long enough that there's some deformity occurring in the non-contractile non-contractile tissues. Sorry about that. That allows it to maintain a little bit more length after the stretch is completed. Plasticity is the tendency of soft tissue to assume a new length after being stretched. So rather than returning to that tight, short length that started, plasticity is when you gain some length after a stretch. So if you've been super tight in your pecs or something after working out and you stretch them and then you feel less tight and less restricted, that was plasticity, that over time holding that stretch, you gain some new length. These are just the structures of skeletal muscle. I don't personally think you need to study it too much, but just to be kind of aware of what's what. We go into some of it more a little bit later, so I'll kind of come back to this. All right, morphological changes with immobilization. So I put this picture on here. This is a guy, lives actually around here, that was on a show called I think it was called Fit to Flab to Fit, something like that. Fit to Flab to Fit. I'm probably way off. But basically it took personal trainers around the world that were already in good shape, and they stopped working out and ate and gained weight, and then they got back into shape with the clients they were training. And so this was a guy that was in shape, and then over time with immobility, didn't work out, he didn't maintain his healthy habits and ate more, whatever, he was able to put on a bunch of weight. He actually did it intentionally, and then worked out with his personal training client and got back to his prior size. But just to kind of show you an example of what happens when you go from working out to not. This is kind of an extreme example, but yes. So the things that are decreased with immobilization, this could be if you're bedridden, this could be if you have a cast on an area, or this could be just if you went from working out to just sedentary lifestyle. There will be a decrease in contractile proteins, muscle fiber diameter, and myofibril number. Intramuscular capillary density, that's the blood supply to the muscle, and motor unit recruitment. So basically that means there's less of the components the muscle needs to contract, including the proteins and the nutrients from the blood, and there's less ability to maintain, to recruit other motor units to create a larger contraction. That's where strength comes in, the ability to recruit more motor units in order to get a large contraction. The things that increase fibrous and fatty tissue within the muscle. I kind of like this. Now, I know one of the pictures is closer than the other, but if you look at his arms, if you measured the diameter of his arms or his chest before and after, it doesn't look like they got much smaller. What looks like happened was the muscle tone decreased and the fibrous and fatty tissue within them increased. So the diameter didn't change that much, but how they are developed and what they're made of did. Atrophy occurs more quickly in tonic or slow twitch muscles, postural muscles, than in phasic or fast twitch muscles. Okay, so one way that I think about this, your slow twitch, your tonic, are your postural muscles. So they're basically on all the time. Like let's say you have a job where you're standing all the time. Your postural muscles, those slow twitch, have to be on all the time. If you went from standing 8 hours a day for a job to sitting 8 hours a day for a job, then that's a huge change. It's like working out 8 hours a day to nothing. And so that's going to create a large effect on those muscle fibers versus fast twitch. You're just using when you're doing a quick spurt of energy. So you might be using those when you're weightlifting, when you're carrying heavy groceries, when you are going up and down steps or things like that, things that you don't do as often. If you do them, you might do them for 5 minutes at a time or 30 minutes at a time, and then you don't do them again until the next day or whenever. And so it's one of those things that you don't use it as often, so it takes a little longer to see a difference in those. Okay, so with the slow twitch, they're on all the time, and once you turn them off and you are not using them, there's going to be a huge difference, and they are going to decrease more quickly. With the fast twitch, you just use them every once in a while anyway, so if you turn them off for a day or two, your body might take a little time to notice that they were even off. All right, if you have questions, let me know about that. All of these changes that I mentioned lead to decreased force generation in a muscle. So that basically means they can pick up less weight. And atrophy can begin in as little as a few days to 1 week. So if you were bedridden for 1 week, you might see some significant drop in your muscle tone or the size, the diameter of that muscle. Immobilization and adaptation. When a muscle is immobilized in a shortened position, the sarcomeres actually absorb and the length of the muscle shortens. Now, when they're immobilized in a lengthened position, there's not a lot of evidence that new sarcomeres are created, but just that they're realigned so that they stretch more. So the ones that are there just are realigned in a better position so that they're able to stretch more to their maximum length. If, let's say, they did serial casting and they got some new length in somebody's Achilles tendon, if they use that new length consistently, like they start walking on a flat foot rather than toe walking, then they'll maintain that length. However, if lengthening exercise aren't continued often, especially when the lengthening is in the muscle, the contractile tissue, we're not talking about in the tendon itself, so my first example was not the best, then it will go back to how it was before. If they don't use it, they will lose it. So if you gain length, like say you do yoga for a year and all of a sudden you're just Mr. Stretchy, and you decide, hey, I met my goal, now I'm going to stop. Give it a year, and you'll be like, I might as well not have done that yoga for a year because I can't tell any difference. I'm back to where I started. All right, Now, if a muscle is immobilized, like let's say it's in a shortened position or whatever, the effects typically last about 3 to 5 weeks after they are able to fully move again, as long as they're going through their prior movements. So let's say they were immobilized in this position and now they're using their arm for functional movements, straightening it often, then within 3 to 5 weeks, they'll pretty much be back to where they were before they had the cast on. If they're not going through their full range of motion, maybe it's painful and they're kind of muscle guarding, then it's likely that it will either take longer or they may not reach their full length if they never push it. All right, neurophysiological properties of contractile tissue and muscle spindles. Some of these slides have a little bit of information at the bottom, just kind of for your reference as you're going through the PowerPoint. You're welcome to look at that. But this is a roadmap of where we're going. So we're going to look at muscle spindles, Golgi tendon organs, neurophysiological response of muscles to stretch, stretching and the stretch reflex, and the PT emphasis. I'm good. I don't think I have anything. Thank you, Mr. Kenny. All right, muscle spindles. They act as a stretch receptor. They receive and convey information about changes in muscle length and how fast those changes occur. That's the muscle spindle. So it's a little fiber that's kind of coiled around the muscle, and as the muscle is stretched or contracted, they send feedback back to the brain to say, hey, we're getting stretched. And some of this feedback is actually relayed at the level of the spinal cord. We'll go through a little bit of that in a minute. But these are muscle spindles. They are stretch receptors that tell you what's going on. Am I getting lengthened? Am I contracting? What am I doing? The Golgi tendon organ, this is a sensory organ. It monitors changes in muscle tendon units. It's typically found in the tendon, so muscle tendon units. So the Golgi tendon organs are right there in the tendons, and as muscles pull and put pressure on the tendon, the Golgi tendon organ sends information to the level of the spinal cord, and that information then comes right back around and has an impact on what the muscle does. Okay, so it's sensitive to even slight changes. It's transmitted at the level of the spinal cord, and it's there for a protective mechanism. So if you do a really quick movement that your body is going to interpret as dangerous, then you will have a reflexive movement back in the opposite direction. So if I quickly jerk my arm out and my body wasn't expecting it, now sometimes your brain can override some of this, but if I quickly do that, then the Golgi tendon organs will send a signal to the spinal cord to tighten back up. Like you're doing too much, dude. Just come on back. And so if I'm going too fast, then in too sudden of a movement, it will tighten up. That is the stretch reflex, and that's something we want to avoid when we're doing like passive range of motion or manual therapy or stretching to a patient, because if you're wanting to elongate a muscle but you move it too fast, you're actually going to cause it to contract and pull against you. It also will react to too much resistance, like if you're picking up too much weight or something, and when you're sustained in a position for too long. I have examples at the bottom. Let me see if my computer will exit me out. Come on, computer. Oh, yeah. Got it. Golgi tendon organs. So they react to extreme stretch, significant tension, or high velocity movement. So, and they're there to keep your muscle from tearing, from getting injured. All right. I'm going to make sure I said all that. The stretch reflex. That's what I just talked about. Golgi tendon organ sends a signal to the spinal cord when the muscle is moved or stretched too quickly, and it causes that muscle to reflexively contract. So in order to avoid that, if we're wanting to stretch somebody and get their tissues to elongate, we need to stretch them slowly. Quick movements cause the muscle to contract. Autogenic inhibition. This is kind of the opposite. When you are stretching slow and you maintain a position for a long time, remember about 30 seconds is kind of the key, then there is a signal again at the level of the spinal cord that is sent to the muscle that says, we're going to be here a while. Go ahead and relax. Let's let your guard down. We're going to stay in this position a while. So then it allows the muscle to relax. So if you hold a stretch for more than 30 seconds, a signal is relayed back to the muscle that says relax. This is one of the main reasons that a low load prolonged stretch is most effective. If you have the muscle in a stretch position that's comfortable, that you're able to withstand for a long duration, then that is the most effective way to increase a muscle's length. All right, some of the non-contractile tissue properties. So with connective tissue, it is made of collagen, which increases your stability, elastin, which increases your extensibility, reticulin, which helps with muscle bulk, and then ground substance, which reduces friction and provides nutrients. So the fibers can slide on one another and not get adhered to themselves. I was thinking I had something at the bottom of these. Okay, I made new slides so that I had was able to talk about them. Okay. All right, so here's some of the behaviors of these connective tissue, these non-contractile tissues. With collagen fibers can elongate quickly with light loads, but then when there is tension, they stiffen. This is what helps you create enough force to pull against tension without ripping your muscle or the tendon itself. So collagen is in the non-contractile tissue, so in the tendons and ligaments, and it moves when you just put slight pressure, slight loads, but with increased pressure or resistance, or increased tension, it resists. The fiber organization is related to the tissue's function, so it's kind of similar to the muscle tissue surrounding it. And the tissues with parallel fiber orientation, like tendons, are able to withstand even greater tensile loads than tissues in which the fiber's orientation is more random, which is skin. If you saw in the last thing down here, tendon organization is the most parallel. Ligaments are kind of like braided together or laid across each other. And then skin is laid at random. So skin can't take as much tension as ligaments, and ligaments can't take as much tension as tendons based on the way that the fibers are laying. And luckily, whenever we're doing certain things, the tension is on the ligaments and the tendons, not just on the skin. If you tried to weight lift and the skin was the only thing holding it up, it would rip. Mechanical behaviors of connective tissue. So collagen resists tensile deformation. It resists that deformity that occurs with tension. So in this picture, collagen is represented by these white strands, and in a young person, they're nice and organized and strong and standing up tall. And in an aging person, they start to kind of break down and be less available in that dermis layer of skin, which then allows divots in the skin, which is what we see as wrinkles. So that's one reason that taking oral collagen can really be helpful in anti-aging benefits. Elastin gives way to tension. Elastin is these green substances here, and it allows the tissue to be deformed, which we need because constantly things are touching us and pushing on us and pulling on us, and it needs to be able to be mobile and move. But it also needs to keep its same shape when it is moved and not be deformed. So the collagen resists deformity, and it's 5 times stronger than elastin, but elastin can move easily, and it's 15 times able to withstand 15 times more elongation than collagen. So it's able to be pulled further, stretched further without being damaged. Types of non-contractile tissue. We have ligaments, tendons, joint capsule, fascia, and skin. And I'm sorry, I hadn't done this in a video lately, but I'm getting that 2 o'clock yawn feeling. We'll go over each of these in this picture. All the white that is connecting the muscle to different areas on the skeleton is fascia. Fascia is connective tissue. Here, the pink is, of course, muscle. The area right here is the tendon. Remember, muscle is connected to bone through a tendon. There's bone there, and then the ligament connects one bone to another. So 2 bones are connected together by ligaments. Bone is connected to muscle by a tendon. I always think of it as 10 is greater than 1. It's 2 different things that are connected, versus with a ligament, there's no number in there. It's the same thing that's connected. All right, so with ligaments and tendons, ligaments are bone to bone. They produce joint stability. Tendons are bone to muscle, and they allow the bone to move as the muscle contracts. A joint capsule, so in this picture, the articular surface is highlighted in yellow, and all the blue that's surrounding is the joint capsule. It's a fluid-filled sac that encapsulates the joint. So it surrounds it and it lubricates the joint, helps bring nutrients in, helps keep a little bit more of a cushion flowing, and allows movement along 2 joint surfaces. Fascia is connective tissue. It surrounds muscles and organs. Here's a beautiful picture of fascia connecting these muscles, and it's web-like in appearance. It's just under the skin. It connects. It was the white in the picture here. All this white is fascia, which is connective tissue. And then adhesions of fascia can actually exert extra pressure, and that can restrict movement, and it can cause pain. There's a lot that's came out in the last few years about myofascial pain syndrome and things like that. And actually, what acupressure and acupuncture both do is they both target myofascial restriction. So dry needling actually can help with some myofascial restrictions, but it can also help with other like trigger points and things. It can go through the layers all the way down to the bone, so it will help release tension in the fascia and the muscle, versus dry needle, that was dry needling, versus acupressure just goes down to through the fascia, so it doesn't affect the tightness of the muscles. But there are superficial layers of fascia and there are deep layers of fascia as well. I'm sorry. I was up randomly in the middle of the night doing this PowerPoint. So I'm tired. But that's my fault. Skin. It provides protection to internal elements, and it has a low resistance to tension. I know I don't have a lot of bullet points on here, but skin is amazing. If you've ever really thought about the fact that it is waterproof and it can move however we want to move and keep water out, but also allow moisture in and allow some things to pass while keeping others out, and it can be torn and repair itself. It's pretty amazing if you think about it. If you think about other materials, as far as like what our clothes are made out of, can't think of anything that really is breathable and really highly mobile, but yet still waterproof and stretch resistant and all the things that skin are. So it's pretty awesome. And here's kind of what it's made of. Of course, we know epidermis, dermis, and subcutaneous tissue. That's where your fat is. There's little muscles that attach to the hair cells that allow them to stand up straight if you're cold. There are nerve endings that go to the epidermis. That's one reason if you have a cut or a burn that goes all the way down to the dermis, sometimes it's not quite as painful as one that just stays on the surface. If you remember the feeling of like a rug burn, it's really painful versus kind of a deep cut in that area may or may not be quite as painful depending, but it's because all the nerve endings are in the epidermis. So a more shallow injury could actually be more painful because of the nerve endings being exposed to the open air. Within the muscle itself, we have endomysium, that separates individual muscle fibers. Then we have paramysium, which encases muscle fiber bundles. And then we have epimysium, which encases the entire muscle. So we have individual fibers that are encapsulated in 3 different layers of connective tissue. The stress-strain curve, there is a point, I know I want to read some of this stuff below for this. So the difference between stress and strain: stress is force that is applied, and strain is the amount of deformation or lengthening that occurs in response to that force. Tension is when the force is a lengthening force. Compression is when it's pushing together. And then shear is when 2 forces are going in different directions. Like if you have something pushing it 2 different ways, that is a shear force. With this curve, initially in the toe region, the collagen fibers begin to straighten. They're kind of wavy to begin with, and they start to straighten. Past the toeing region, you start to get in the elastic region. So as you add more stress, some deformation or lasting lengthening occurs. The more stress you add or over a longer duration, the more lengthening that is maintained up until a certain point. So necking, all right, okay, we'll do plastic regions, okay. Once the elastic limit is reached, then failure of collagen fibers and tissues occurs in the plastic range. So this area right here represents the area where collagen fibers are starting to fail. That causes heat to be released, and then they're left with a permanent increase in length. With the point X and Y, it's basically if you don't put as much pressure, you'd be at X, and if you put more, you'd be at Y. So it just, you're left at a further point depending on how much tension or pressure you're putting on the area and how long it's held. Necking is the region where there's considerable weakening of the tissue and less force is required for tissue failure. Failure is the point where a tear occurs. So failure is the point of injury, and necking is the point where you could easily get injured, but you're not there yet. So if you're trying to gain muscle length, you need to at least go past the elastic limit and go to the plastic range. So with the elastic range, that basically means you can go through that range and go right back to your previous length. With plastic, once you go towards that range and hold it for long enough, you're going to maintain some extra length. One of the things that we can kind of look at in regards to this is like sprain grades. So a sprain is damage to a ligament. A strain is typically talking about a muscle or a tendon. Some sprains, they also are talking about tendon. But anyway, the grades can be related to the stress-strain curve. Grade 1 is a micro failure. So just a few fibers are typically ruptured, and it's kind of in the lower part of the plastic range. So just kind of beginning to be in that plastic range. Grade 2 is macro failure. There's a larger number of fibers that are ruptured, and it creates more of a partial tear. So this is kind of a true injury. With the grade 1, if you allowed enough rest and just non-threatening movements like light activities, passive and active range of motion and stuff, then it would heal back on its own. With a grade 2, there may be some scar tissue after it heals. There may be some, lasting injury. And then grade 3, it's a complete rupture or complete tissue failure. Tissue creep, this is just saying that so first tissue creep increases, you're starting to gain length, and then it levels off and remains constant. And the same with time and with relaxation and returning to normal. So this, you're lengthening it, you're stretching it, it starts to lengthen and it gets to a place where it's going to just level off. And then when you're returning back to your prior position with relaxation, it's getting a little bit longer over time and it gets to a point where it levels off. Oh yes, the tension also, yeah, the tension, sorry, the second one is not relaxing. This is the tension within the muscle. I'm sorry. Top one I explained correctly. Bottom one is the tension within the muscle. So the top one is the creep over time. The bottom one is the tension. So like with your hamstrings, you start stretching them, you feel like they're super tight, and over time you're like, oh, it's relaxing. I can maintain this. That's what this one is. Over time, it gets more relaxed and is able to maintain that position with less tension. All right, so tissue creep. Load applied without return to original length upon removal. So creep means there's some lasting changes. The amount of change, the amount of deformation or lengthening that remains depends on the amount of force that's applied, the rate of force that's applied. So it's time dependent. You want to hold it for a long duration and you want to do a low level of force. Increased levels of force create more injury. Low levels create just length without the pain and the inflammation. So that is another reason we would like to use low load, prolonged stretch to get in that tissue creep region and be able to maintain that elasticity, that length that you gained. With low magnitude loads for long duration, this allows the collagen to remodel. So if you're holding a stretch for a long time at a comfortable range, then the collagen can remodel and become more like the tissue that it's supposed to look like in more of a lengthened position. With stress relaxation, when a force is applied to stretch a tissue and the length of tissue is kept constant after the initial creep, that's that first little part of the curve, there's a decrease in the force required to maintain that length, and the tension in the tissue decreases. We already talked about that with the two curves on the PowerPoint. And so if you get into a position, the longer you hold it, the less tight that muscle feels and the easier it is to hold. This is another underlying principle of why we do a low load, prolonged stretch. And even while we do like splinting, like overnight splinting, that was in the last picture. This is a night splint for somebody with plantar fasciitis, or serial casting. All of those things can be done in order to increase the length. Now, if you're doing serial casting, those can be left on for days or weeks at a time. If you're doing more of a low load, prolonged stretch, just holding a position, we typically do 15 to 30 minutes and at least twice a week in order to really gain effects. Ideally, you would do it daily. Cyclic loading. Now, cyclic loading is basically like lifting weights. You're repetitively adding resistance to a muscle. You're repetitively loading the tissue. So it would be like doing reps of something or carrying boxes in over and over. It can increase the strength of collagen over time, and that would be the training effect. So if you are, careful about how much weight you're loading and how many reps, and you're listening to your body and you're allowing for proper healing time in between and all that stuff, then over time, repetitive cyclic loading, repetitive movements on that joint will increase the strength of the collagen. However, it can also break down connective tissue and collagen if you're not allowing enough rest time, if you're not properly hydrating, if you're progressing the exercise too quickly, like the whole couch to 5K and however long, if you're starting too quickly and doing too much too fast. And this is what causes a lot of your stress fractures, your overuse injuries, all those types of things, your chronic inflammation type things are because of cyclic loading, too much, too fast, not enough rest, not enough recovery, and it breaks down the connective tissue. So a collagen supplement could also help with recovery and to decrease injury after workout as well. All right, some of our key points that I want you just to be aware of with stretching. Deformation requires appropriate force and rate of force applied to the connective tissue. So typically we apply a slow force and enough pressure that it's slightly uncomfortable but not painful. Elongation or flexibility requires the breaking down of collagen bonds and then realigning the collagen. With immobilization, the tissue's tensile and contractile strength decreases and adhesions increase. So if somebody's been immobilized, most likely you're going to have to do some breaking down of scar tissue and some increasing on range of motion and stretching in order to realign those fibers. With injury, weaker type 3 collagen is laid down and it's not converted to a stronger type 1 collagen until about 3 weeks after injury, which is another reason you have to really progress people very slowly. And you can't just say, well, you were an athlete before, I'm just going to start you at this weight. Because even though they could do that before, they don't have the same strength of collagen. So they're kind of out of place for at least 3 weeks after the injury, where they could re-injure a lot easier than the initial injury itself. Other factors that affect collagen realignment are age, injury, medications, and activity, diet, hormone imbalance, dialysis. There's a lot of things that can affect the collagen. So take that into consideration with your specific patient. And then in treatment, allow for healing of fibers and use newly gained range of motion to ensure maintenance. If you get extra motion, you need to use it or you'll lose it before the next treatment. You'll be starting over every time. So what are interventions to increase soft tissue mobility? So besides stretching, we can also do manual or mechanical stretching using an external force. So rather than them stretching themselves, you could passively stretch, which is pretty much the same. The patient relaxes and you move them through. They can do an assisted stretch, so maybe they stretch themselves and you add a little overpressure. You can do contract relax, where you stretch until their last point, and then they push against you, and then once they relax, you push it a little bit further, and then they push against you, and once they relax, you do it a little further. And typically, they'll hold it about 5 seconds each. So you push them until it's a little uncomfortable. They relax in that position 5 seconds, then they push against you just slightly so that you're able to keep them where they are. So if they push so hard that it moves your arm, then it's not helping. But if you're able to stay where you're at and they push just slightly against you, then when they relax, you should be able to gain a little extra. That's contract relax. And I typically do 5 times 5 seconds. So relax for 5 seconds, contract for 5 seconds, and repeat that pattern 5 times. And then self-stretching, they stretch themselves. Stretching intervention. So there are various types of stretching. Why do we stretch it? Well, if somebody has an adhesion or a contracture or scar tissue, if they have muscle weakness and it's caused it to shorten, if they've done vigorous exercise, remember exercise can break down the tissues and a repetitive contraction is shortening the tissues, so we need to lengthen them back to maintain their length. All those are indications that they need to stretch. As we talked in class today, ideally you would stretch. The best results are from stretching after exercise, but kind of a dynamic warm-up is suggested that goes through the full range to prevent injury during exercise. Contraindications: if there's bone blocking your stretch, don't do it. If there is a fracture that has not properly healed, don't stretch that area. If the area has significant acute inflammation, you don't want to stretch, or infection, because you could spread that infection. Significant pain: if there is a significant hematoma, that's a bruise, then we wouldn't stretch because tissue is already damaged and we don't want to add more tension to that damaged tissue. Hypermobility: if already they have too much movement, you don't want to overstretch and cause more movement because that'll cause instability. Functional use of hypomobility, we talked about that. If it's more functional for them to be tight, let them be tight. And then diseases that affect stretched tissues. If they have some type of disease where overstretching, causes their tissue to break down, or they don't have the ability to repair that, then you have to be very careful and avoid overstretching areas, or stretching at all if it's going to be, depending on the type of disease. Precautions: don't push past their normal range, or a normal range. So don't try and get this crazy amount. It would create some instability. If they have increased risk for fractures with osteoporosis or steroid use, be careful so that you don't create a fracture. And avoid aggressive stretching of immobilized joints, just to avoid injury as things are healing up. All right, to properly apply some stretches, first, apply the force in the appropriate direction for that muscle. If you need to stabilize, then you can stabilize, like in the picture, they stabilized with a belt, holding the pelvis in a neutral position so that it didn't come off of the table. Make sure you have the right intensity, typically a kind of low intensity, so it's kind of uncomfortable but not painful is ideal. The duration of the stretch, at least 30 seconds would be ideal in order to gain movement. Static stretching is the best. Static progressive can be used. Like I said, you take them kind of to their end, you hold it for a while, and then when they feel pretty loose, you can push it a little bit further and then hold it there. And then cyclic or intermittent stretching, that could be done throughout activity, just to kind of keep things warm and moving correctly, and keep lactic acid from building up in the area. Speed of stretch: it's important to go slow. Ballistic or bouncy stretches are not recommended, although in some sports they do those. It may help with a certain sport if they're doing a bunch of jumping and movements like that, just to prepare them for those movements. But otherwise, ideally, static stretching would be better. Again, a dynamic warm-up is good, and static stretching at the end would be great. High velocity stretching in conditioning programs and advanced phase rehab. If maybe they're a kicker or a cheerleader that needs to be able to do a high kick really quickly, then that could be something that you could practice, but it would be kind of a high level. You wouldn't do that with just the average person. Frequency of stretch: if you want to maintain new range, then it needs to be performed at least 3 times a week, and if possible, daily. That would be the best case scenario. When we're stretching, we typically want to first warm the tissues up. You could use heat. You could also use a exercise bike or walking or something like that. And then if you're doing a manual stretch, we'll typically hold 15 to 60 seconds. I mentioned this in class today. You may not have heard it, but still ideally you would hold it 30 seconds, but sometimes when you're holding it, your position, it's hard to maintain for 30 seconds. So that might be actually for the therapist's body to maintain good biomechanics and stuff, rather than what's best for the patient. If you're doing a self-stretch, 30 to 60 seconds is ideal. Of course, the therapist is assessing the patient and cueing them for good form, even if they're doing self-stretches. With mechanical stretching, you always want to do a low load, and it's typically more like 15 to 30 minutes, unless it's something like continuous, like a night splint they wear all night, or a serial casting that they wear for a few weeks at a time. All right, so PNF, proprioceptive neuromuscular facilitation. I say this every time I teach it because I really believe it. If you want to do a lot of PNF, you really need to get certified in PNF. It's very specific on how you do it and on where you hold, hand placement, and speed, and all these things, because you are trying to activate some muscles while relaxing others. We'll show you some PNF patterns in lab. Some of the techniques you can use the hold, relax, and contract, relax technique. So you push the patient to the point of resistance, and then they do a slight contraction against you, and then you push them fast once they relax. That was kind of what we talked about earlier. I've done that with hamstrings. I find it to be pretty useful in stretching people's hamstrings. Agonist contraction, so you contract the opposite muscle and hold, and then rest after each rep. So contracting the opposite muscle should send an inhibitory message to the muscle you're wanting to stretch and allow it to relax better. The hold relaxed with an agonist contraction. So you stretch the tissue that you're wanting to get a stretch. You do an isometric contraction and then relax, and then immediately contract the antagonist and hold that one for 4 to 5 seconds. Now, I honestly don't know the benefits of that over the others. That's somebody that would have to be well versed in PNF to really explain that and go into that. Another reason I say if you want to do a lot of PNF, you need to be certified in it. But these are just different techniques that can be taught when you're learning PNF in order to help a patient increase muscle length. Some pointers: make stretches functional. I've mentioned before, but when you make something functional, the person does them more often and they're more compliant with that. So if you're able to say, every time you have a break at work, lean forward in your chair and lean forward and stretch your hamstring, or every time you go to do this in your house, reach up and stretch your arm overhead, then they'll do it more often and get more benefits from it. Always include stretching in the home exercise program. Otherwise, you'll be kind of starting over every time they come to the clinic. Neck muscles are easily strained. I do not recommend overpressure on neck stretches when possible. And if a patient is using low load prolonged stretch, make sure they're in a comfortable, sustainable position with other body parts in good alignment. What you don't want to do is end up straining the back while you're stretching the hamstrings because they're in a weird position, arching their back or something. Get them in a comfortable position that they can hold for a long time before you give them that stretch to do. Some of the things that have been found to complement stretching is relaxation training or Pilates, yoga, some of those things. Some of the elements in relaxation training are mindfulness, deep breathing. There's different approaches out there. If you'd like to learn more about the approaches, you're welcome to, and you could use those in your therapy. One I see used most often is deep breathing, because the diaphragm has so much to do with your ability to contract and relax your pelvic floor and your transverse abdominis, and those are kind of your key core stabilizers. So that's a good one to learn and develop that information. But these are just coupled with stretching. Modalities that can be coupled with stretching: you could use heat. Sometimes it could warm the muscles up in the beginning rather than like an active movement. Cold, I would only use after. We do not want to stretch a cold muscle. The only time I have seen something that is against that is maybe a cold spray. If they're in a lot of pain, spray that area with a cold spray and then stretch. I don't recommend that unless maybe it's like an athlete on the field and you just need to get them back in the game quickly, something like that. Otherwise, I do cold at the end after stretching. Massage can help relax the muscles. It can help mobilize and manipulate the tissues. Biofeedback can help. Traction and oscillation can help. And then there's a little case scenario if you want to kind of go through and a little review of some of the things that we have went over so far this semester. We've already covered several chapters. It doesn't feel like it because it's just moving by so quick. But if you have questions, make sure that you let me know, and I will see you in lab.